Hi everyone, my name is Deb Bondi and I am excited to talk to you all today about persistent pulmonary hypertension of the newborn, or PPHN. I have nothing to disclose. Our objectives today are to explain the pathophysiology and diagnosis of persistent pulmonary hypertension of the newborn, or PPHN, describe the goals of PPHN management, and evaluate current treatment options for patients with PPHN, including blood pressure management, pulmonary vasodilators, and surfactant. Here I have a list of abbreviations for you to refer back to later if needed, and I also have these in the footers of the relevant slides throughout the presentation. First, let's discuss PPHN pathophysiology, as this is really paramount to really understanding our treatments that we'll discuss later. The pathophysiology of the fetus fundamentally differs greatly from that of the newborn, both structurally and functionally. Transitioning from intrauterine life to extrauterine life requires rapid and complex steps to ensure neonatal survival, and ultimately PPHN is a failure of this normal transition. Normal fetal circulation essentially bypasses fetal lungs, since they already receive oxygenated blood from their mother via the placenta. There is very low systemic vascular resistance and very high pulmonary vascular resistance, which guides blood flow away from the lungs. And then after birth, the newborn needs to transition to oxygenating themselves via their lungs. So the systemic and pulmonary vascular resistance essentially swap, so that the systemic vasculature is now the higher pressure system. Again, in PPHN, this normal circulation does not fully transition. To further explain this, we must discuss the foramen ovale, which is a shunt between the left and right atria. And then the ductus arteriosus is what I like to describe as a bridge between the pulmonary artery and the aorta. In normal fetal circulation, where the pulmonary vascular resistance is higher than the systemic vascular resistance, there is a right to left shunt across both of these to again shunt blood away from the lungs. In a normal neonatal circulation, we want blood to go to the lungs, and our systemic vascular resistance should be significantly higher than our pulmonary vascular resistance, so blood should flow now left to right through these remaining shunts, which should eventually close. During a normal fetal to neonatal transition, several cascading reactions occur that help facilitate this process. The first inspiration that the baby takes after birth distends their lung cavities, and this leads to dilation of the capillary network, which causes an 8-fold increase in pulmonary blood flow to the baby. These events induce a transient state of shear stress, and then in response, endothelial enosynthase, or eNOS, production is upregulated. And this eNOS stimulates the amino acid L-arginine to produce nitric oxide. Upon release from the vascular endothelium, nitric oxide elicits the release of other endothelium-derived pulmonary vasodilatory mediators, which include things like substance P, vasopressin, angiotensin, and histamine. Next, nitric oxide and prostaglandin I2 diffuse through the endothelium, which enters the vascular smooth muscle, both of which eventually lead to pulmonary vasodilation and a reduction in pulmonary vascular resistance. Pulmonary artery pressure thus decreases by 50%, which permits pulmonary blood flow to increase in the baby by 10-fold. And then with each subsequent breath that the baby takes, the partial pressure of carbon dioxide, or PaCO2, decreases and their blood pH normalizes. So again, in simple terms for PPHN, that all does not go to plan and the transition is incomplete. If we continue on with what should happen in normal transition, clamping of the umbilical cord increases systemic vascular resistance and left atrial pressure. This encourages the initial functional closure of the foramen ovale. Now that the pressure in the aorta is higher than in the truncus pulmonalis, the right to left shunting that was present before birth should change to a left to right shunt. Additionally, clamping of that umbilical cord leads to a loss of prostaglandins, which previously helped keep the right to left fetal shunts open. The partial pressure of arterial oxygen, or PaO2, in the aorta increases since the blood is now oxygenated by the newborn's lungs, and this increase in PaO2 results in smooth muscle contraction in the wall of the ductus arteriosus, which thus results in a functional seal and helps with that closure. Again, with PPHN, these processes do not adequately occur, And this failure to transition to extrauterine life is what ultimately leads to the development of PPHN. This failed transition generally occurs as a consequence of another comorbid condition, and there are four main types of PPHN which have been identified and reported throughout the literature. These include maladaptation, maldevelopment, underdevelopment, and intrinsic obstruction. So maladaptive specific PPHN is characterized by abnormal remodeling of the pulmonary vasculature. This leads to hyperplasia and thickening of vessel walls, impaired blood flow, and impaired gas exchange. Sepsis currently accounts for approximately 30% of these maladaptation-related cases, and then other causes of maladaptive PPHN include meconium aspiration syndrome, RDS, asphyxia, and pneumonia. Maldevelopment specific PPHN is characterized by remodeling of the pulmonary vasculature itself in the presence of normal lung parenchyma. This is often idiopathic, but it's also been associated with things like chronic fetal hypoxia, fetal anemia, and in utero closure of the ductus arteriosus, most commonly due to maternal NSAID use. Underdevelopment specific PPHN, which is lung hypoplasia, is not as common as the other types of PPHN. However, it is notably associated with worse outcomes. So this type of PPHN is associated with diseases like alveolar capillary dysplasia, congenital diaphragmatic hernia, also known as CDH, and oligohydramnios. And lastly, intrinsic obstruction of the pulmonary arteries due to hyperviscosity is also associated with PPHN. So this type of obstruction increases PVR, and newborns born to diabetic mothers are at increased risk of polycythemia and should be monitored for this potential complication. Physical exam of the newborn with PPHN includes tachypnea, tachycardia, grunting, retractions, DSATs that are unresponsive to supplemental O2, as well as cyanosis. Also notably, there's a differential in oxygen saturations if you compare them pre and post ductally, so before and after the ductus arteriosus. In other words, how they functionally do this is that they measure the oxygen saturation in the lower extremities as well as the right upper extremity. And if the lower extremities are at least 5% higher than the right upper extremity, this would be concerning. An echocardiogram, or echo, is the gold standard for diagnosis of PPHN. Findings suggested of PPHN on the echo include right to left shunting across the PDA and or the PFO, or at least bidirectional shunting, right ventricular dilatation and high systolic time interval, shortened pulmonary blood flow with high pulmonary artery pressure, and then flattening or bowing of that intraventricular septum. The oxygenation index, or the OI, is one index used to appraise the severity of PPHN. You can see the equation listed here. Notably, newborns with an OI greater than 25 may benefit from inhaled nitric oxide. So what you'll commonly see in clinical practice is that if you're at an institution that does not have ECLS capacities, that you'll probably transfer to an ECLS center if your OI is rising over 20. The chance of mortality also increases as the OI increases. The incidence of PPHN is 1.9 per 1,000 live births in the United States, with mortality estimates variable but up to 33%. So goals of pharmacological treatment in PPHN, there's several. The first is to optimize lung inflation. The next is to minimize overall oxygen demands of the body. Then we treat any underlying parenchymal disease. We sustain cardiac performance and hemodynamic stability. And lastly, reduce pulmonary vascular resistance, or PVR. To achieve each of these goals, our treatment strategy is very multimodal. First, our ventilation strategies are used to optimize our lung inflation. Next, sedation with or without paralysis will help us minimize our oxygen demands. Next, surfactant, antibiotics, or any other management strategies should help treat any underlying issues that are worsening the situation. Our blood pressure management will help us sustain cardiac and hemodynamic performance. And lastly, we will utilize pulmonary vasodilators to reduce pulmonary vascular resistance. As pharmacists, I'll focus the remainder of this presentation on the drugs we've used for those different categories. You can see those that we will be discussing listed in the table here. Okay, I'm a sucker for a good history timeline. I took a deep dive to see a sort of evolution of pharmacological PPHN management. It really starts in the 1960s when the beginning of our recognition of this right to left shunt occurred, and then, recognizing that pulmonary hypertension is there. The first pulmonary vasodilator described was used in 1965. The drug was tolazoline, which is not a currently FDA-approved medication. Back then, we used to refer to this disorder as persistence of fetal circulation, or PFC, but in 1976, we coined the term PPHN in the literature. Surfactant was first described for use in patients with pneumonia and meconium aspiration in 1991. Nitric oxide was then used in 1992 with the first major randomized trial for it in 1997 and ultimately FDA approved for neonates with PPHN in 1999. PGI-2 was also first described in the late 90s. Sildenafil was first described for pediatric pulmonary hypertension, which included PPHN in the early 2000s. A few years later in 2006, milrinone was first described. And so really you can see here quite a large spread of new strategies trialed over the last many decades, with continued research ongoing in the last 20 years or so to optimize management. Systemic hemodynamics should be optimized with volume and inotropic therapy to enhance cardiac output and systemic oxygen transport. Common agents that we utilize include dopamine, epinephrine, and milrinone, and then vasopressin and norepinephrine have additionally become more appealing agents for the management of PPHN. The American College of Critical Care Medicine provided guidelines in 2017 on the management of hemodynamic support of pediatric and neonatal shock. And they have some key recommendations specifically for newborns with PPHN and hemodynamic shock, and they are summarized here. This includes initial volume resuscitation, followed by the addition of dopamine with or without dobutamine, ensuring that we focus on the middle dose range of dopamine so that we're targeting beta-1 adrenergic receptor stimulation and increased myocardial contractility. The next agent to add would be epinephrine. Hydrocortisone would be added with concerns for adrenal insufficiency. And lastly, milrinone can be added to further improve cardiac contractility. Similar but slightly different, a NICE review article was published in the Clinics in Perinatology in 2021, and this provided an expert approach to PPHN management. So similar to the American College of Critical Care Medicine, it similarly starts with fluid resuscitation and then dopamine at the middle dose ranges again. Next, there are 3 strategies to consider. Similar to before, it includes epinephrine and hydrocortisone, but this expert opinion here also recommends consideration of norepinephrine instead of epinephrine. It also outlines the use of alprazolam if the ductus arteriosus is closing and right ventricular dysfunction is present. Similar considerations for milrinone and dobutamine are included in this expert opinion, although dobutamine I would say is much later down the line in this algorithm. And then vasopressin is mentioned in this algorithm, although it's as a 4th line agent, but it is included. And then special situations where you would maybe choose to consider one agent over another are included in the light blue box on this slide. And this includes epinephrine, which you would consider if there is decreased left ventricular function or decreased pulse pressure. Norepinephrine when there is comorbid sepsis or there's a decrease in systemic vascular resistance or an increase in pulse pressure. Milrinone when you note RV or LV dysfunction, and then dobutamine when milrinone would not be suitable for the patient. Now we'll briefly go over each individual agent. First, dopamine. This has remained the mainstay first-line therapy for neonatal shock, at least in the United States, for many years. So at low to moderate doses, dopamine predominantly focuses on the stimulation of beta-1 receptors, which leads to cardiac stimulation and increased cardiac output. Doses in the higher range, as you get closer to 20, actually increase your systemic vascular resistance through stimulation of alpha-1 receptors. However, importantly, this vasoconstrictive effect is not localized just to the systemic vasculature, and you should remember that this could also worsen pulmonary hypertension by also increasing pulmonary vascular resistance. Similar to dopamine, epinephrine at low to moderate doses predominantly focuses on the stimulation of beta-1 receptors, which again leads to cardiac stimulation and increased cardiac output. This may be especially beneficial for a newborn with depressed myocardial function. And again, like dopamine, as you get doses in the higher range, not only do you increase SVR, but you may actually worsen pulmonary hypertension by increasing pulmonary vascular resistance. Recent data notably demonstrates that very, very low doses of even 0.01 to 0.02 in neonates can be effective as well. The addition of norepinephrine may further increase systemic vascular resistance through stimulation of those alpha-1 receptors. It has pretty minimal effect on inotropy through beta-1, while vasoconstriction through, again, the stimulation of alpha-1 receptors may increase your pulmonary vascular resistance like we just discussed for dopamine and epinephrine. Clinically, there's actually evidence, surprisingly, to suggest that the ratio of pulmonary to systemic arterial pressure actually decreases following norepinephrine infusion, which would be ideal in newborns with PPHN. Dobutamine increases cardiac output through its inotropic effect from the stimulation of beta-1, while remaining relatively SVR neutral. It also has a chronotropic effect, which demonstrates an increase in neonatal heart rate, especially at those higher doses. Vasopressin does not act via alpha or beta receptors like the previous drugs we just mentioned, but rather via 3 subtypes of vasopressin receptors. V1 receptors have potent vasoconstrictor properties on the systemic vasculature with minimal effect on the pulmonary vasculature, leading to decreased pulmonary to systemic arterial ratio pressure. Additionally, vasopressin is thought to produce pulmonary vasodilation via stimulation of oxytocin endothelial receptors and subsequent nitric oxide pathway activation. So that potentially makes vasopressin an ideal agent for PPHN when thinking about those mechanisms. Milrinone is a PDE3 inhibitor and an inotropic agent. So as such, milrinone is also a pulmonary vasodilator. So we'll discuss it again in the later section, but this potentially makes milrinone the preferred drug in the setting of left ventricular dysfunction. The vasodilation can also occur systemically, not just in the pulmonary vasculature. So hypotension is a serious side effect to think about when it comes to milrinone. Many experts do recommend against using the loading dose due to concern for significant hypotension with that big initial bolus. And these experts rather just start the continuous infusion despite the longer half-life of this medication. Next, we'll move on to pulmonary vasodilators, which through various mechanisms of action result in reduced pulmonary vascular resistance and allow increased blood flow through the lungs. First, we'll start with inhaled nitric oxide. The use of ionotherapy is currently the gold standard for term and near-term newborns with severe hypoxic respiratory failure, and it is currently the only FDA-approved vasodilator specifically for the treatment of PPHN. Studies have demonstrated that INO improves oxygenation, decreases the need for ECMO therapy in newborns over 34 weeks gestation with diverse causes of PPHN. Outcomes with INO in PPHN greatly improve, including a reduction in the need for ECMO and a reduction in the need for oxygen at 30 days of life. Inhaled INO enters well-recruited alveoli, and then this diffuses into the smooth muscle of the pulmonary arteriole. From there, INO binds to the heme moiety of cytosolic guanylate cyclase, which activates it and increases the intracellular levels of cyclic GMP. And this leads to smooth muscle relaxation. Dilation of pulmonary vessels in well-ventilated lung areas, which is where the INO is able to get to, then helps to redistribute blood flow away from areas where ventilation perfusion or VQ ratios are poor. And so this is ideal in the setting of PPHN. The oxygenation index, or OI, we described earlier, helps providers determine when to initiate INO. They recommend starting at a dose of 20 parts per million. Generally, patients who fail to respond to INO at 20 parts per million will usually not demonstrate an improvement at higher doses of 40 or even 80 parts per million. But studies have shown that brief exposure to these higher doses does appear safe, at least, with the exception of for patients who are on 80 parts per million for a sustained amount of time, that they do have a higher risk of methemoglobinemia. Thus, dose escalation could be considered in refractory cases, but you'll see some conflicting practices with that. INO molecules react with lung water, oxygen-containing heme molecules, or hypoxic blood. This oxidation reaction reduces heme iron to the ferric state, which forms methemoglobin and nitrate. Methemoglobin exhibits a higher affinity for oxygen, but it's comprised of fewer heme moieties to bind with that oxygen. So given the reduced oxygen carrying capacity, the oxyhemoglobin dissociation curve shifts leftward. So when methemoglobin levels are high, a dose reduction of INO is warranted. The next pulmonary vasodilators we'll discuss are the PDE5 inhibitors with a focus on sildenafil. Phosphodiesterase 5 or PDE5 inhibitors include sildenafil, tadalafil, and others. The first two have been published in the literature for PPHN, although I would say sildenafil is the most widely studied for this indication. Inhibition of PDE5 in the smooth muscle of the pulmonary vasculature results in an increase in cyclic GMP, since PDE5 normally degrades cGMP. And as you remember, increased cGMP concentrations will then elicit that pulmonary as well as systemic vascular relaxation, which leads to vasodilation. Sildenafil is available both enterally and intravenously in the United States. In addition to use during the acute phase of PPHN, you'll also see some institutions utilize sildenafil to help facilitate weaning off of INO as the patient is clinically improving. Dosing of sildenafil in clinical practice is pretty variable, as there's been a wide range of doses that have been studied. Studies report that an oral dose of 0.5 to 2 mg per kg given every 6 hours offered similar exposure to therapeutic dosing in adults, while oral doses of 1 to 3 mg per kg given every 6 hours has been shown clinically to improve oxygenation and mortality in resource-limited settings who don't have access to INO. Intravenous sildenafil is commonly given as a loading dose of 0.4 mg per kg over 3 hours with a continuous infusion of 0.07 mg per kg per hour. However, there are some issues with IV compatibility, although some of this has improved with some more recent studies, but still some centers utilize an intermittent dosing strategy with a PO to IV conversion of sildenafil of 2 to 1, and then they administer those intermittent doses over 1 to 3 hours to help get rid of some of the compatibility issues. And the primary adverse event to monitor for with sildenafil is systemic hypotension, because as a reminder, that vasodilation you get from it occurs everywhere, so you do get systemic vasodilation as well. The next class we will discuss are the PDE3 inhibitors, which includes milrinone. As a reminder, milrinone was previously discussed in the blood pressure section, since it also functions as an inotropic agent for PPHN. So due to this, milrinone is likely the pulmonary vasodilator of choice in patients with left ventricular dysfunction, as we mentioned previously. Its mechanism specifically for pulmonary vasodilation is through that PDE3 inhibition, which results in increased concentrations of cyclic AMP. So similar to cyclic GMP, cyclic AMP results in pulmonary vascular relaxation and therefore vasodilation. Again, similarly, this effect doesn't just occur in the pulmonary vasculature, and it also occurs in the systemic vasculature, so definitely something to keep in mind. Milrinone is available as an intravenous medication. It's given as a continuous infusion with or without a loading dose, like we previously mentioned. If you do decide to give the loading dose, the dose is typically 50 mics per kilo given over an hour. Again, some centers have decided to forego this. The continuous infusion dose range is typically 0.25 to 0.5 mics per kilo per minute, titrated up to a maximum of 1, which has demonstrated an improvement in infants with PPHN who have been refractory to INO in studies. Doses should be reduced in the setting of renal dysfunction, as this can lead to accumulation of milrinone. So similar to PDE5 inhibitors, the primary adverse event to monitor for with milrinone is systemic hypotension, because you get that systemic vasodilation as well. And then additionally, it is an inotropic agent, so you always want to monitor for potential dysrhythmias. Next, we will discuss prostacyclins, which are also referred to as prostaglandins. So prostaglandins have been used in patients with INO-resistant PPHN due to their ability to cause pulmonary vasodilation. These include PGI2, which the PGI2 specifically is what are called prostacyclins, and the drugs are epoprostenol, iloprost, and treprostinil. PGI2 medications cause pulmonary vasodilation by increasing the production of cyclic AMP. Both the intravenous and aerosolized or inhaled routes have been utilized for various PGI2 medications, and the dosing is really limited to case series and retrospective evaluation, so not as set in stone, but I'm going to go through some of the literature for the different dosing strategies that have been utilized. So one study initiated intravenous continuous infusion epoprostenol in newborns with PPHN refractory to INO, and they initiated at a dose of 4 nanograms per kilo per minute, and this was increased as needed by 2 up to a maximum of 20 nanograms per kilo per minute. This demonstrated a response in 15 of the 36 newborns that were studied. Nebulized epoprostenol dosing typically ranges anywhere from 10 to 100 nanograms per kilo per minute as a continuous nebulization. The initial dose has varied, but I would say it's most commonly initiated at 50 nanograms per kilo per minute, although there is a study that initiated as low as 10. The largest evaluation to date included 43 newborns, and this demonstrated a significant improvement in OI after just 12 hours of treatment with nebulized epoprostenol. One study utilized IV iloprost as a rescue therapy for PPHN, and this demonstrated a significant reduction in the median OI as well as other markers with starting doses of 0.5 to 3 nanograms per kilo per minute, and this was titrated to maintenance doses of anywhere from 1 to 10. Inhaled iloprost was compared to sildenafil in a retrospective study, and this was administered via a jet nebulizer at doses of 1 to 2.5 mics per kilo every 2 to 4 hours. When they compared this inhaled iloprost to sildenafil given enterally, 0.5 to 3 mg per kg every 6 hours, interestingly, iloprost demonstrated faster response to treatment as well as an earlier ability to discontinue the study drug due to clinical improvement. A similar dose of inhaled of 1 to 2 mics per kilo every 2 to 6 hours has been studied in preterm neonates. Another study utilized inhaled 1 to 2 mics per kilo every 3 to 6 hours as a first-line medication when INO was unavailable, and this also demonstrated improvement in full-term neonates. Treprostinil is an intravenous or subcutaneous infusion. It's mostly been studied in newborns with CDH. One study initiated at 6 nanograms per kilo per minute, titrated up to a max of 21 nanograms per kilo per minute. This was then transitioned to a subcutaneous continuous infusion once the patient was stable. Treatment was overall well tolerated in 14 of 17 neonates eventually being discharged. Another retrospective review of patients with CDH found a typical intravenous initiation dose of about 4, and they titrated up to a typical dose of about 20 to 30. And then there's 2 case reports of use after CDH repair where they reported much higher maximum doses of even 48 and 52 nanograms per kilo per minute. Additionally, there's 2 case reports described in preterm neonates with PPHN who had early onset sepsis and they were refractory to INO. In these preterm neonates, they received IV treprostinil at 5 nanograms per kilo per minute, titrated up to a max of 20, and both patients demonstrated significant improvement with no systemic side effects. So definitely some variable dosing there. Notably, the intravenous route for prostacyclins carries a significant risk of causing hypotension, again due to systemic vasodilation. This would be a bit minimized if you think about it from the nebulized or inhaled route, where you're going to have a lot less systemic absorption. It should additionally be noted that epoprostenol has an extremely short half-life of approximately only 6 minutes, so operational processes need to be in place at each institution to ensure a replacement product is always available to prevent rebound pulmonary hypertension if an issue were to arise. Additionally, injection site reaction should be monitored for those patients getting the subcutaneous infusions. And our last pulmonary vasodilator we will discuss are the endothelin receptor antagonists. Endothelin receptor antagonists block endothelin receptors on endothelium and vascular smooth muscle. The stimulation of these receptors is associated with vasoconstriction, thus blocking this results in vasodilation. Bosentan is the most commonly studied drug in this class for PPHN, and it blocks both ETA and ETB receptors with a slightly higher affinity for the A subtype. Bosentan's major role may be for patients who continue to have chronic pulmonary hypertension after their initial acute PPHN episode, since its oral availability would be convenient for outpatient administration. Additionally, trials have shown that bosentan is pretty well tolerated for acute PPHN, despite only being enteral, but its use for PPHN is really declining in that acute phase due to data demonstrating sort of variable efficacy and not really consistent improvement in those patients. Bosentan is only available as an enteral tablet, so it must be compounded into an oral solution. It's typically dosed at 1 mg per kg per dose enterally every 12 hours and may be increased up to 2 mg per kg per dose. And then serum, AST, and ALT, as well as bilirubin, should be monitored, ideally prior to initiation, and periodically thereafter to monitor for hepatotoxicity. This diagram provides that similar expert opinion from before on the blood pressure management. These same experts provided recommendations on the ventilation and treatment strategies to improve pulmonary vasodilation, specifically in PPHN. First, non-pharmacological management with optimizing lung inflation is paramount. That sedation we've previously talked about to minimize overall oxygen demand, and correction of underlying issues, including acid base and electrolyte status, which can worsen pulmonary vasodilation. Our first line pulmonary vasodilator, after oxygen, which is also a pulmonary vasodilator, the first drug you would use is inhaled nitric oxide at a dose of 20 parts per million. After this, these experts recommend a trial of either IV sildenafil or inhaled prostacyclin. And then for patients, again, with right ventricular or left ventricular dysfunction, they would recommend milrinone. And then lastly, we will briefly discuss surfactants. Surfactant deficiency can occur in patients with PPHN who have underlying RDS, meconium aspiration syndrome, or other injuries such as pneumonia. Exogenous surfactant therapy has been shown to improve oxygenation and reduce the need for ECMO when PPHN is secondary to parenchymal lung diseases, which are the things that I just mentioned. This includes both studies where patients receive surfactant at earlier OIs of 15 to 20, as well as patients who received it at the higher OIs of the upper 30s who are already on nitric oxide. There are currently 3 FDA-approved surfactant products. These include Baractant, Calfactant, and Paractant Alpha. Exogenous pulmonary surfactant serves as a replacement for endogenous surfactant in patients who have surfactant deficiency or surfactant inactivation. Surfactant, whether it's endogenous or exogenous, reduces that surface tension at the air-liquid interface of the alveoli during ventilation, and this stabilizes the alveoli against collapse at resting transpulmonary pressures. So overall, this restores surface activity to the infant's lungs. Surfactant therapies are available in varying vial sizes. They're administered endotracheally or intratracheally. Dosing has varied in the studies. They're similar-ish to RDS, but with a little bit of variability. So Paractant Alpha, for example, has been studied at a dose of 100 to 200 mg per kg, which is equal to 1.25 to 2.5 mLs per kilo of Paractant Alpha. Baractant has been studied at a dose of 100 to 150 mg per kg, which is 4 to 6 mLs per kilo of Baractant, with the ability to repeat doses at various intervals of 6 to 12 hours, up to multiple doses for each agent. One expert suggests reducing the dose of surfactant by 50% in patients with CDH who have evidence of surfactant deficiency because they would, have pulmonary hypoplasia and so thus have less lung that needs surfactant. And then frequent monitoring of oxygen saturations and arterial blood gases are necessary to prevent hyperoxia as well as hypocarbia that could occur after you dose surfactant. Adverse effects of surfactant include endotracheal tube obstruction and pulmonary hemorrhage, which should be monitored for. That's a wrap up of our review of PPHN management. A few key takeaways for you today. PPHN is caused by impaired fetal to neonatal transition, and so this leads to persistence of the elevated PVR from fetal life. Initial management includes optimizing lung ventilation, sedation, and correcting underlying issues. Blood pressure management should focus on increasing cardiac output and systemic vascular resistance, while ideally being PVR neutral or even decreasing PVR. Nitric oxide is the gold standard pulmonary vasodilator in PPHN. Additional pulmonary vasodilators to trial before ECMO include sildenafil, inhaled prostacyclins, and milrinone. And lastly, surfactant should be considered for PPHN due to parenchymal lung diseases. Let's move on to our self-assessment question number 1. Here we have a 1-hour-old newborn who is showing respiratory distress. She had meconium-stained amniotic fluid at delivery. Her oxygen saturation is poor and you suspect PPHN. Which of the following statements best describes the pathophysiology of PPHN in this patient? Is it A, insults such as meconium-stained amniotic fluid trigger a reaction that induces pulmonary vasoconstriction and new onset pulmonary hypertension after birth? Is it B, early closure of the ductus arteriosus and foramen ovale after birth results in a lack of ability to oxygenate blood due to the loss of left to right shunting? Is it C, continued high pulmonary vascular resistance shunts deoxygenated blood right to left from the pulmonary artery to the aorta? Or is it D, meconium-stained amniotic fluid itself blocks the ability for left to right shunting across the ductus arteriosus, and this leads to inadequate oxygenation of blood to the body? So the answer here is C. It is continued high pulmonary vascular resistance that shuts deoxygenation of blood from right to left across the pulmonary artery to the aorta. Answer A is incorrect because the increased pulmonary vascular resistance we see is persistent from fetal life, and this is not a new onset high PVR. Answer B is incorrect because it is normal for the ductus arteriosus and foramen ovale to close after birth, so this alone does not contribute to PPHN. And answer D is incorrect because the meconium-stained amniotic fluid itself does not affect shunting across the ductus arteriosus. The hypoxemia and hypercarbia associated with this condition does lead to an increase in PVR. Okay, self-assessment question number 2. Which of the following statements regarding blood pressure management in newborns with PPHN is true? A, dopamine is initiated first line and should be dosed 15 to 20 mg per kilo per minute. B, milrinone should be strongly considered with RV or LV dysfunction. C, norepinephrine has been shown to worsen the PVR to SVR ratio. Or D, epinephrine has no role in the management of hypotension in PPHN. So the answer here is B. As a reminder, milrinone not only is an inotropic agent, but also produces pulmonary vasodilation, which makes it an ideal agent for patients with RV or LV dysfunction. Answer A is incorrect because dopamine should ideally be dosed in a range of 5 to 10 mg per kilo per minute so that you have that inotropic effect while minimizing the higher doses that cause vasoconstriction, which can worsen PVR. Answer C is incorrect because surprisingly, norepinephrine has been actually shown to improve the PVR to SVR ratio, despite causing kind of that similar vasoconstriction as dopamine and epinephrine. And answer D is incorrect because epinephrine is a reasonable agent to consider after dopamine for the management of blood pressure in babies with PPHN based on guidelines and expert opinion. All right, next question. Which of the following pulmonary vasodilators would be associated with the least systemic hypotension as an adverse effect? Is it A, enteral sildenafil, B, intravenous sildenafil, C, intravenous milrinone, or D, inhaled epoprostenol? The answer here is D. Utilization of an inhaled or nebulized route will minimize the side effects from systemic administration, and systemic can be enteral or IV, thus A, B, and C are incorrect. Moving on to question number 4. Which of the following would be a reasonable approach to pulmonary vasodilators for the management of PPHN? Is it A, initiate INO, first line, consider the addition of sildenafil or inhaled prostacyclins as a second-line agent, and then consider milrinone with RV or LV dysfunction? Is it B, initiate enteral sildenafil first line while the OI is still low to prevent the need for expensive therapies like INO? Is it C, initiate INO first line, then add bosentan as a second-line therapy and consider milrinone with RV or LV dysfunction? Or is it D, initiate INO first line and consider the addition of IV prostacyclins over inhaled due to increased efficacy with systemic exposure, and then consider milrinone with RV or LV dysfunction? The answer here is A. As a reminder, INO is always our first-line pulmonary vasodilator, and then your options thereafter, as recommended by expert opinion, could include sildenafil or inhaled prostacyclins, or the use of milrinone for patients with RV or LV dysfunction. So based on this, answer B is incorrect. Sildenafil would not be first line. Similarly, answer C is incorrect. Bosentan is not consistently demonstrated benefit in PPHN, and we would generally not use it for this. And lastly, answer D is incorrect because the main reason to use inhaled over systemic is a reduction in side effects, not necessarily that IV has improved efficacy compared to inhaled. And our last question, which of the following patients with PPHN would be the best candidate for surfactant administration? Is it A, a neonate with congenital diaphragmatic hernia who's mechanically ventilated on 100% FiO2 and unresponsive to INO? Is it B, a neonate born with meconium-stained amniotic fluid currently on CPAP with an initial echo showing left to right shunting? Is it C, a neonate with culture positive early onset sepsis, who's currently on 2 liters of high flow with oxygen saturations of 98%? Or is it D, a neonate with concerns for RDS, who's mechanically ventilated on 100% FiO2 with an initial echo showing bidirectional shunting? The answer here is D. Surfactant would be beneficial in babies who have PPHN thought to be due to parenchymal lung diseases, and that would include something like RDS. The patient in answer A does not have any mention of anything that would sound like a parenchymal lung disease, just the CDH, so would not necessarily be a candidate unless we thought there was also surfactant deficiency or inactivation. The patient in answer B still has left to right shunting, so nothing on the echo currently indicating pulmonary hypertension. And the patient in answer C is still only on high flow and is not demonstrating severe disease or severe surfactant deficiency. Listed here are my references for you to review. And thank you all for joining me today.